Okay then. Good evening, everybody. I would first like to thank the AIOC for giving us this opportunity to conduct this IC on primary rheumatogenic retinal detachment management. The topic of this IC is current trends and accumulated experience. The important thing of this particular group of instructors is that they are all having an experience of more than 25 years and are all practicing vitreoretinal surgeons, and they are practicing all the methods which we will be discussing. So there's a lot of experience here, and I think we should be able to give you a very clear idea of how we should manage retinal detachment in this current era. The other common link of all these co-instructors are that all are alumni of Shankar Nethralaya, and I'm very proud that we are all together here today. We'll be basically covering all aspects, and in the end, we'll have a panel discussion also. I would now request Dr. K.S. Kumar to start with his talk. It will be on, he'll have two talks. One will be on laser treatment for management of rheumatogenic retinal detachment, and the other talk following this will be on pneumatic retinopexy. Dr. Kumar is, as I said earlier, an alumnus from Shankar Nethralaya and has been trained in his MBBS as well as MS from Bangalore. And for his MS, he was in PGI Chandigarh. And subsequently, he did his fellowship from Shankar Nethralaya and has been active practicing VR surgeon in Bangalore since the last 25 years. Is very active academically and also writes very well. So we hope Kumar gives us a good view of these two topics. Kumar, please go ahead.
Am I audible, sir?
Yeah.
Thank you very much. I would like to thank the original selectors for selecting the instruction course and the immediate selector, Nitin, my dear friend, for including me as part of this symposium. I'll be giving two tandem talks. The first is about laser photocoagulation for primary rheumatogenic retinal detachment. A prayer that we should recollect is, from making the cure of a disease more painful than the endurance of the same, good Lord, deliver us. The remedy ought not to be worse than the malady. So we will talk about the role of laser photocoagulation in the management of retinal detachment. The role is really limited. It dates back to 1968, and Okun and Sibis were the first to describe this. And they described this as delimiting laser photocoagulation for limited RDs, and they qualified what a limited RD is, as you can see from the various parameters that they describe. Now, it's really an expectant therapy, the idea being to wall off or demarcate, or to use common day parlance, to quarantine the troubled retina from the rest of the retina. And it finds its use in apprehensive or infirm patients who are at poor surgical risks or unwilling for definitive therapy, a lack of resources, either financial or technical expertise in the locality that the patient stays. So where do we really employ these? There are a set of indications which we should be very clear: peripheral, preferably phakic, flat, shallow RDs without the surface corrugations or the rugae, old inferior RDs, and CMV related retinal detachment, peripheral retinoscasis with outer layer large breaks and inner layer tiny breaks, tiny atrophic breaks or dialysis with small subclinical fluid, or limited RDs which are asymptomatic and incidentally detected, also useful in post-scleral buccal recurrent detachments, some cases. So these are photographs to show vitreous cases with large outer layer and inner layer breaks, which is peripheral, and this is a limited peripheral detachment. And the way we go about it is we wall off this with several rows of laser and carry it anteriorly right up to the ora serrata. 3 to 4 rows of confluent gray white LIO is preferable. Treat any other associated lattices also, and the adhesions usually start by 24 hours. The limitations, of course, are that it's not a definitive procedure, and breakthrough RD is always a possibility. This needs to be explained. It's a stopgap, makeshift arrangements. No well-defined criteria, but whatever indications we just discussed would be ideal. It has its share of problems like epimacular proliferation, full thickness macular holes, rubeosis iridis, vitreous hemorrhage, new large breaks from necrosis from over-treating. But on the contrary, on the flip side, it's a simple, time-efficient procedure, inexpensive, and no need for any personnel except the treating doctor. So the role of really observation versus laser DLP in some of these cases is not really established. But however, we have seen in our clinical practice that some degree of additional protection is afforded. And in very rare situations, there may be even a reattachment with the PVD plug that happens in some of these post-laser. Coming to laser after retinal reattachment, extension of the same concept, post-scleral buckle, we do use, in cases of, instead of cryo, we can use them particularly post-pneumatic retinopexy or post-vitrectomy. Of course, we do endolaser, and transscleral diode retinopexy can treat through buccal elements. These are pictures to depict patients who have been treated with delimiting laser. A shallow RD post buccal that was treated with delimiting laser, and the retina settled over this buccal. This is an inferior detachment where delimiting laser has been done. And this is from the literature. An angioma-like lesion over the detached retina developed 2 years after this. So it is thought to be related to the additional ischemia induced by the laser scars. Coming to the next topic, which is pneumatic retinopexy. It was really Hilton and Grizzard in 1985 who reintroduced the concept and refined the concepts of pneumatic retinopexy. It's an office-based procedure which involves use of intravitreal air or gas to achieve retinal reattachment with retinopexy with either cryo or laser. All of us are aware that it's the buoyant force or the flotation force of the gas bubble that occludes the retinal brake, preventing fluid influx from the liquid vitreous through the hole, and it displaces the fluid inferiorly, and the SRF is absorbed by the RPE pump. So just another animation diagram to show how exactly retinal reattachment is achieved. Coming to the role of cryo versus laser, generally it is preferred to use cryo in patients with anterior breaks or suboptimal media clarity, but some vote for laser, particularly in breaks that are highly elevated, large, posterior or multiple breaks, or whenever a steamroller procedure is planned. We will come to that in a bit. It causes less reaction than cryo and faster sticking. And in the event of a recurrence, we have virgin retina to treat these patients. So the initial criteria was the size of the break should not be greater than 1 clock hour, should be in the superior 2/3 of the fundus, and PVR not more than grade A or B. Ability to maintain position is a very critical factor. And of course, no history of severe glaucoma or no cloudy media, which precludes proper examination of the fundus. So these are, now there is an extension of the indications. Multiple breaks within 1 clock hour of each other also have been many times successfully managed with pneumatic retinopexy. But the important thing is the patient should be able to maintain 16 hours per day almost for 5 days immediately post procedure. So this is the diagrammatic representation of how it's done. We treat with cryo and then the gas is injected. We will talk about that in the next few slides. The way to go about doing the cryo, it's very important to treat around the break and not in the bed of the break, so as not to increase the chances of pigment fallout and subsequent PVR. This is the apparatus that is needed, the gas. I'll not be going into the details of this because time wouldn't permit. This is a video which is, unfortunately, that video is not playing. So it's usually done under peribulbar anesthesia that gives the added comfort to the patient and also prevents any vasovagal episodes from the pain that the cryo may cause. Visualize all retinal breaks, apply cryotherapy, perform anterior chamber paracentesis, and inject either 0.3 ml of C3F8 or 0.5 to 0.6 ml of pure SF6 gas. Check the optic nerve head perfusion, and then, of course, the post-operative instructions to these patients. The gas bubble enlarges by influx of nitrogen, oxygen, carbon dioxide, water vapor, and the type of gases in use depends on the situation. But now we more often tend to use SF6 alone, because the longer a gas lingers in the vitreous cavity without really serving its purpose, the chances of new breaks increase. So unless the patients have very large breaks and where post-operative tamponade is needed for longer periods of time, posterior breaks, we never use C3F8 these days. This is a slide to show the arc of contact, the bubble volume and the arc of contact in normal length eyeballs and eyeballs with myopia. Now, as we alluded to earlier, we inject 0.3 ml. Those are the concentrations of gas which are safe to be injected in patients with normal intraocular pressures. The break should be uppermost in the postoperative positioning. We can use a marker on top of the iPad to indicate to the patient. This has been named as Tonam's pneumo level, who described it. So Paul Tonam was the one who described. So this is easy for the relatives and the attendants to position the patient postoperatively. Coming to issues, there can be problems with the procedure. The point of injection should be the uppermost aspect of the globe, and only after inserting the needle, about 30 gauge needle into the vitreous cavity, we withdraw and allow just 1 to 1.5 mm of the needle to be within the vitreous cavity before injecting into the bubble. Brisk, steady injection should be done. Very slow or very rapid injection, and too much of the needle in the vitreous cavity can produce this fish eggs and subsequently air getting under the retina. Another thing, if the needle is not fully penetrated, is the presence of the gas in the prehyaloid canal of Petit, causing a donut sign. A strict prone positioning may sometimes help in this situation. This particular procedure is not without its share of complications. A whole list of things can happen. The most important, of course, being recurrent retinal detachments, unless the case selections are done properly. Now, this is another complication which can happen in patients with macula on detachments. You see that the macula here is attached, and then when you inject gas, the fluid moves backwards because the gas tamponades the brake, and the fluid that was there moves backwards and induces a macular detachment. So to prevent this, steamroller maneuver is required. Immediately after injecting the gas, the patient is placed prone, and over 15 to 20 minutes progressively, as can be seen in these diagrams, is progressively allowed to take this position. Of course, this is, it comes with a increased risk of PVR, but it decreases the risks of retinal folds in these patients and macular detachment. This is a diagram from, Hilton's original paper, which shows that the oblique meridians colored in brown are the most difficult to tamponade when employing pneumatic retinopexy as a form of treatment. We need to be aware of this. These are some pictures of pneumatic retinopexy in an upper temporal macula on RD with successful reattachment. This is a successful pneumatic retinopexy for RD that developed, much to our surprise, following macular hole surgery with a sclerotomy related PEC. This was in the era of 20 gauge instrumentation, successfully reattached with pneumatic retinopexy alone. Now, many times we can have a residual RD that refuses to, a very, very obstinate RD, peripheral RD that refuses to settle down despite no obvious brake leaking post-scleral buckle. So you can very usefully, gainfully employ pneumatic retinopexy for settling these RDs, as we can see here. These are some of the extended indications. It has been tried in inferior brakes or even fresh GRTs with mobile flaps. Extreme head positions of extreme flexion or extension will have to be employed in these patients. This is a patient post-vitrectomy, again in the 20 gauge era, who developed a large giant retinal tear, but much to our surprise, with a double bubble technique where we injected another bubble after 48 hours, we were able to salvage the eye with pneumatic alone. So it's very important to be aware of when not to employ brakes in the inferior half, 1/3 of the retina, or already more than 4.5 clock hours, extensive lattice degeneration or the brake itself being huge, proliferative retinopathy, anything greater than, more than grade C or D, tear with a large bridging vessel or vitreous traction on tear for risks of recurrent detachments or vitreous hemorrhage. And of course, very important, if you have not viewed the retina thoroughly, there is really no scope for doing pneumatic retinopexy, because almost always we will be punished with recurrences, or the patient has impending air travel, then we avoid pneumatic retinopexy. This is a sobering study which tells us, which is very, very recent, which tells us that pneumatic retinopexy as compared to vitrectomy in the management of primary rhegmatogenous RD, the pivot study which showed better best corrected visual acuity with pneumatic, lesser vertical metamorphopsia, and even lesser incidence of morbidity. So we all need to take notice of this and give pneumatic retinopexy its pride of place. It's a very useful tool to have in our armory, but must be used very discreetly and wisely. It can be a real savior in specific situations outlined before, and simplicity, as Leonardo da Vinci said, is the ultimate sophistication. It is a rescue surgery. If we have to resort to scleral buckling or vitrectomy, as the case may be, if retina doesn't reattach by 3 to 5 days, or if the macula is still detached. Now, it has somewhat fallen into disfavor for reasons of being an economic disincentive. We should not be goaded by this factor alone. And the key to success is truthful fundus examination. So I leave you with this thought: is pneumatic retinopexy unpopular because it is inexpensive, or is it unpopular because it is inexpensive? I leave you with that thought. Thank you very much for your patient hearing.
Thank you, Kumar, for your excellent talk. You covered both the topics in a very precise manner. Thank you very much.
Thank you.
Now I'll be taking up the next topic. That will be scleral buckle for the management of rhegmatogenous retinal detachment. Is my screen visible?
Yes, sir. We can see it, sir.
Okay, so the role of scleral buckle in management of primary retin detachment is quite important, because I think almost 70 to 80% of the primary retinal detachments usually fall in the preview of possible management with scleral buckle. Though in the present era, with newer techniques and especially the popularity of vitrectomy with the good new equipments, it has probably slightly fallen back in popularity. But I think it's an art which we should all preserve, and it really works in most of the cases. So for me, I think the basic advantage, the principal advantage of using scleral buckle in management of primary rheumatologic retinal detachment is that it's more or less an extraocular procedure. It does not disturb the internal milieu, and it is suitable for all age groups. You can do it in an infant as well as in an old person, and it is very good for phakic RDs. The other important thing is the rapid retinal reattachment. So now we have detachment which has a definite break and a partial RD. I think it's straightforward. Or even if you have multiple breaks but a partial RD with no obvious PVR, again it's a good case to treat with scleral buckle. And if you have such breaks in superior temporal region with additional break here, you do the scleral buckle, and next day in 24 hours your retina is attached, and at 1 month retina is absolutely fine. So it's a if done properly, and if the case is selected properly, I think you get really gratifying results with scleral buckle. So for me, the indications would be a single or multiple buckles, which are definite. You know that you have seen the retina well, and you know these are the only breaks, and I think that is a good indication. Absence of significant PVR, any PVR less than C2 can be considered for a scleral buckle. Young phakic patients, it's always a procedure of choice. Aphakic patients with well-dilating pupil and clear vitreous, where you can see all the breaks well, I think also a good case to be operated with scleral buckle. And pseudophakic patients, again, where the pupil is well dilating, the vitreous is clear, and you can see the breaks. I think that's a good choice to consider scleral buckle. However, if the patient has such multiple breaks, margins, those are, I would not tend to consider this for a scleral buckle. And if there is definite PVR more than C2, no question of considering scleral buckle, and obviously in extreme PVR, so there is again no doubt that we should consider other possible surgeries. Here again, a giant dialysis following a cataract surgery, we were doing scleral buckle procedures. As Omar had rightly pointed, for pneumatic retinopathy, same applies for scleral buckle. Half the scleral buckle surgery is done before the operating, before the patient enters the operation theater. That means you have to do a very proper dilated indirect ophthalmoscopy, proper detailed drawing, and you should plan and only then go in and start the surgery. That helps in getting good results. So there's no two ways of avoiding this. You may not always do a surgeon who has been practicing for a long time may not always do this unless he has a help from his fellow to do this detailed drawing. But at least he can make a quick drawing on his paper or on his chart. So that because what happens sometimes is the patient may not come to you for surgery immediately. He will show you and then go back and come after 2-3 weeks. So I think going back to your notes would be helpful. And sometimes in the intermediate period, the patient develops synechiae, his cataract increases, the media gets hazy. So you don't know really what the primary situation was. So doing a drawing in the beginning when you see the patient for the first time is always helpful. And having a plan how to consider this surgery also helps in making your job easy. Usually, I prefer to do these cases under local anesthesia. Unless the patient is very apprehensive, we may add sedation. And for all children below 15, we would consider to do it under general anesthesia. Also, other one indication for general anesthesia are people who are claustrophobic. I have patients who just refuse to be draped at all. So in these patients, we may have to consider general anesthesia. So if you look at the steps, I'll just briefly go through them. Conjunctival peritomy is very important because in scleral buckle, you want the conjunctiva to cover all your buccal elements for life. So you can't take any chances with doing an FSZ job in opening the conjunctiva. It should be done very delicately and properly. And at the end of peritomy, you make 2 horizontal cuts. And once the peritomy is complete, you dithermize the bleeders and then go ahead with separating the intramuscular septums. Again, care being taken to use blunt instrument and not cause any trauma to the sclera in the entering process. Hooking the muscles also is important. You follow the sequence starting with the inferior rectus, then the 2 horizontal recta, and then the superior rectus. Always you prefer to use the blunt instrument so that you don't cause any trauma to the sclera in this beginning stage of the surgery. Once you identify the muscles, you may pass sutures to hold the muscles and move them around. And once all the muscles are, you check for any weakness. This is very important because if there is ectasia, you may have to change your plan. And I think Dr. Ashish would be talking about in more detail subsequently. Once you see with the use of indirect ophthalmoscopy, you mark the break. This is the area where I mark it with diathermy. You can use a marker or any other instrument you want to mark the break. It's a personal choice. And once that is done, here I'm demonstrating the implant technique. There is a choice of implant or an explant technique. It's a surgeon's own choice depending on his experience. The only thing which you have to be careful in an explant technique is that you take every suture which you take, especially in thin sclera, can potentially cause a scleral perforation. So you have to be very careful in selecting cases for explant techniques. In implant also, as I show, in this case, and we see in subsequent slides, sometimes there can be still problems if you have a thin sclera. Once you have identified this break, you go about 3 millimeters on all sides, anterior, posterior, and on both sides, and make a scleral bed. And as you can see here, till this time that was okay, but at this point there was a little bit of scleral that it went full thickness, and the sclera has been the choroid has been popping out. But we could just still manage. So you can still manage these cases, and in the end we were able to place the buccal well. So once your bed is ready, you mark you check what buccal element you're going to put, decide the size, and then you make tunnels all around in the rest of the quadrants which you use for encircling elements. These tunnels are sutureless. You go all around, and once the tunnels are made, you pass sutures to hold your buccal element. And once that buccal element sutures are placed, you place the buccal along with the encircling element into the sutures, and then pass the sutures all around 360 degree. Once that is done, you make the bed. You can go back into the scleral bed and prepare the drainage side by dissecting the sclera till you see have the choroidal show. And once that is done, I prefer to use a 10 monofilament nylon needle, but you can use even a laser or any other diathermy tip to make the opening into the choroid. So this leads to drainage of the fluid. And once the drainage is complete, you may just tighten up the buckles. Now, this is a very critical step, the drainage, because you can get most of the complications at this stage. You can get hemorrhage from the drainage site. You can get hemorrhage under the retina. So selecting the drainage site, either in the bed, usually over the horizontal recti, is very important. And you should relax your pull on the muscles a little bit when you're just poking. And once you poke and your drainage is started, you would like to pull up the eyeball so that there is no sudden hypotony leading to choroidals in the inside of the eye. So once that is done, you tighten up the sutures, you pull up your encircling elements, and then tighten your encircling element also. After this is done, you immediately check the central retinal artery for any abnormal pulsations. You will digitally check the pressure. If it is high, you immediately take steps to reduce the pressure by loosening up the band. Once this is done, you are now back to your conjunctival areas. You see that the conjunctiva is pulled properly. You are covering all the buccal elements. Nothing is popping out. And then you go for the conjunctival suturing. You can use multiple techniques. I use a 6 or 8 vicryl, but you can also use a glue, or you can use diathermize. You can diathermize the ends. It is a personal choice. And this usually takes care of the surgery. Now, just a quick look on the intraoperative complications. Most of the steps in people who have been practicing this are safe, but you can cause globe perforation right at the local anesthesia injection. So you have to be careful because many of these patients are high myopes. So if you're giving a block in a high myop, you have to be sure that you don't damage the sclera. And you can also cause globe perforation in thin scleras while marking the break. So don't use sharp instrument to mark the break. Scleral dissection can lead to problems. I have shown you just one of the slides. The sutures, if you're doing an explant technique, you have to be careful. Drainage can sometimes be dry, so you may have to select another site. Sometimes if the fluid is moving, you have to do multiple drainage sites. It can lead to hemorrhage, and it can lead to retinal incarceration. If the incarceration occurs in your buccal dissection itself, you can always get covered with the buccal itself. If it occurs in other sites, you will have to probably support it with a fresh buccal. Post drainage, there can also be hypotony, vitreous hemorrhage, and subretinal hemorrhage. You have to take care of that as soon as you do the surgery. Now, in one of the talks, we will be discussing about shifting from buccal to vitrectomy. One of the indications, if the hemorrhage is very severe, you may have to resort to doing a vitrectomy on table itself. Now, the early postoperative period, you may have raised IOP because most of the detachments, the patients have low IOP pre-surgery, and after you attach the retina, the pressure may go up. You have to be watchful for that. There may be choroidal detachments. If it is minimal, it can just slowly get covered, but sometimes you may have to resort to giving systemic steroids. Recurrent detachments in the early phase probably be due to a missed break or inadequate buccal, but in experienced hand, this is not a very common thing to occur. But the only problem is of recurrent detachment will be in a later phase, which I'll see in the next slide. One important thing we should not miss is the ocular ischemic syndromes. If you tighten the buccal too much, and if you see in the post-op period that inflammation is not coming down as you expect, and if the pressure is remaining high, you have to think of ocular ischemic syndrome, especially in younger patients. And I've seen people with 6 and 6 vision, macula on RD losing their eye due to ocular ischemic syndrome. So you have to be very careful about this particular complication. Late postoperative complication would be again maintaining the IOP remaining high for a long time, recurrent detachment due to PVR and buccal infection. All this can be taken care of with other probable surgeries. So to conclude, scleral buccal, it's always been said it's a dying art. I don't think so. We have been using this. I have patients who have followed up even after 22 years and still maintaining a very good vision. So it's definitely, it has still a role to play in the current scenario. It has limitations, so your case selection has to be proper. And obviously there is an economic advantage because this is one surgery you can do with a very basic microscope with a small, simple cryo. And obviously the cheapest instrument is always the surgeon who works for 24 hours. And as we can see, all of us are working for the last 25 years. So to end, this is just remembering exactly 6 years ago, at top of Zurich, these 3 musketeers are enjoying the view. We hope that we get such a opportunity again. We are not meeting in person, but definitely today we are meeting virtually. Even Dr. Vatsal was there in Zurich that time, but not in this photograph. I hope we get this opportunity to meet directly someday in the near future. With this, I'll end my talk and I'll ask the next speaker to take over. Or next speaker.
Nice nostalgia, Dr. Prabhu said. Thanks for putting up that photograph.
Yeah, and exactly as I said, it's exactly 20. The photo is marked 26 June. We were in Zurich on 25th and 26th we went to top of Zurich, if you remember.
So we will all like to be part of the Musketeers.
Yeah, sure. Our next speaker is Dr. Preetham Samant, and Preetham would be Preetham, your slide share?
Yeah. Can you see it?
Not yet.
Yeah.
So Dr. Preetham is currently an associate professor at JJ Hospital and Grand Medical College, and is a consultant retinal surgeon at PD Hinduja Hospital, and has his own group practice. He is also an alumni of Shankar Nethralaya, and as I said earlier, he is presently the president of Bombay Ophthalmic Association. We are very proud of you, Preetham, and also is a very active scientific committee chairman of the Maharashtra Ophthalmic Society. Is literally single-handedly handling the academic activities of BOA and MOS for the last few years. Preetham, can you please go ahead with the topic?
Thank you so much. Thank you for the humble, kind introduction. My topic for the day is vitrectomy in retinal detachment. Can you hear? Can you see the slide?
Yeah.
Yeah. Is it gone to the next one?
Yeah.
Okay. So my topic for today is vitrectomy in retinal detachment, its principles and techniques. So my presentation is essentially divided into 3 parts: indications, the principles, and the modern vitrectomy techniques. So indications, the most common is indication for treating a retinal detachment with vitrectomy would be PVR. As we saw, Dr. Nitin Prabhu Desai gave a fantastic talk on scleral buccal. Scleral buccal is always the first choice when you're dealing with a simple rhegmatogenous RD without PVR. But when it comes to PVR, you have essentially a disease vitreous which has to come out, and hence the choice has to be vitrectomy. In other cases where you have rhegmatogenous RD accompanying with other pathologies like, let's say, vitreous hemorrhage where there is no view, or with an intraocular foreign body which has to come out, or a giant retinal tear where you need to do vitrectomy and roll the giant retinal tear, or probably a drop nucleus or intraocular lens, then you would resort to vitrectomy for rhegmatogenous RD. Another indication, because as advances happen, indications change. Now, although we always say that scleral buckle has its own charm, in the MIBS or the sutureless era, the need of the hour is early rehabilitation. So sometimes there might be situations where you have a rhegmatogenous RD without PVR, but you could get away with vitrectomy, a sutureless vitrectomy, like for instance, a localized superior RD or a superior RD with a single break, or pseudophakic superior RD, because there you're not really worried about causing a cataract due to vitrectomy. So this debate could be endless, it could go for hours together, because you could be debating whether between a buccal and a vitrectomy. In fact, we have a talk on that later on in this course. But if you, but the take on this is, if you can get away with a sutureless vitrectomy, maybe with a gas, because gas means it's a single surgery, you don't have to remove the gas, and early rehabilitation, then maybe that could score above a scleral buckling in such situations. So when we come to principles, how do what are the steps which are important when you're doing a vitrectomy in a rhegmatogenous RD? So the first and foremost important thing is the PVD induction. This is a must and has to be a part of every vitrectomy for rhegmatogenous RD. Nowadays, we use triamcinolone to stain the vitreous. And as you can see in this video, this is the Weiss's ring. The Weiss's ring is an indication that the PVD has occurred. Once the Weiss's ring occurs, then you can go on, with the vitrectomy. You could also use active or passive suction using a silicone tipped cannula to induce, because you have a mobile retina and you don't want to cause a nitrogenic break with a high suction from the vitreous cutter. You could also do a forceps assisted PVD induction. The most important principle is to do a complete vitrectomy. Now, why I've put complete in inverted commas is, you have to be yourself be satisfied at the end that you've done a complete vitrectomy. The rationale being that leaving residual vitreous is inviting PVR and hence recurrent RD. One must also try to excise as much of base as possible, because the base is the thickest part of the vitreous, which can lead to anterior PVR post-operatively. Base excision is more easier in aphakics and pseudophakics, and could be a challenge in phakics because you don't want to cause a lens touch. Base excision and complete vitrectomy could also be a challenge in pediatric and young RDs, where the vitreous is thick and sometimes it's difficult to shave it completely. The next principle is making sure that the retina settles. So flattening and settling the retinal break is important at the end of fluid air exchange. If the retina is intrinsically contracted, then no matter how much membrane peeling and PVR you've removed, and it does not settle, one of the indication of it not settling is you could be having a subretinal air. In that situation, then you may have to resort to relaxing retinotomy. One must remember that having a little bit of pocket of posterior residual SRF is not much of a concern, because if your breaks are flat, then that residual SRF will absorb consequentially in the post-operative period. Doing endolaser and cryopexy to all the breaks, the ones on the detached retina as well as on the attached retina, is very important before inserting the tamponade. Vitreous tamponades, again, we have Dr. Vatsal Parekh who's going to talk on vitreous tamponades. But just to make a mention here, PFCL is an important aspect of vitreous surgery for RD. It acts as a third surgical hand. It is very useful in tackling giant retinal tears. As you can see in this video, there's a giant retinal tear in a highly myopic patient. And after injecting the PFCL helps rolling the flap of the giant retinal tear. You can see I'm rolling the flap and using the PFCL to do that. And then at the end of the surgery, the PFCL also helps in silicone oil PFCL exchange, the last bubble of the PFCL being removed while the oil is being injected. Of course, post-op prone positioning becomes important when you're using tamponades for retinal detachment surgery. Another $1 million question is whether to use a band or not. Again, this could be an endless debate. But the situations where I would use a band in retinal detachment with vitrectomy is when I'm not sure that I've achieved a complete vitrectomy. Probably I would use a band in young and pediatric retinal detachments, in phakic retinal detachments, those detachments there where there is a lot of PVR, and probably for inferior breaks, because inferior breaks will always have some SRF collecting around them. So in these situations, I would sort of use a band because that will be my insurance. Coming to the techniques, it's a huge topic to cover in a short time, but let's just look at the some of the aspects. The MIVS, or the minimally invasive vitreous surgery, the trocar cannula system has changed the game. It's been a game changer. This is a video from 2004 where I'm struggling to cut this vitreous which is spouting from a sclerotomy, a 20 gauge sclerotomy. And this particular action could cause iatrogenic breaks and retina incarcerating into the port. Gone are those days, because by using the trocar cannula system, we are traversing the vitreous sufficiently enough to have to avoid these iatrogenic complications. Again, the valved trocar cannula system also protects from inadvertent hypotony, something which you don't want in myopic RDs. Again, the trocar cannula system also allows us to exchange our ports. You can always move the infusion cannula superiorly, go through the infratemporal cannula and do your shaving of the vitreous in the inferior fundus, thus avoiding lens touch. So these are some of the advantages of the modern MIVS vitrectomy which we do. The high-speed small gauge vitreous cutters again have made a lot of difference. The high cut rate decreasing the surgical time, and there is safety from complications such as iatrogenic breaks because the suction on the retina is less. Again, the small gauge, the augmented tips are very easy because you can go as close to the retina and shave the vitreous as close as possible. Another important concept which some of the machines have introduced is that of duty cycle. The minimum duty cycle is a situation where you can have the same high cut rate, but the port is open for a lesser amount of time. This is just to depict. You can see this is a minimal cut rate on this side where the port is open for a lesser time as compared to here. So in this situation, you will have less amount of turbulence. You can see this. In this situation is less amount of turbulence, and this kind of less duty cycle can be used for shaving, going very close to the retina, whereas the high duty cycle is used when you're doing a core vitrectomy in the mid vitreous cavity. The other principles can't go much into details, but I'll just make few mentions. Better illumination, safer illumination sources such as the LED illumination, then chandeliers have made a lot of difference in the way we are now doing our vitreous surgery with excellent results. The wide angle viewing systems again have changed because we can really go to periphery, we can use a wide angle viewing systems and identify all the retinal breaks. Chromovitrectomy, where we use the triamcinolone to induce PVD, we are using brilliant blue to peel the ILM in those situations where there is a macular hole, have also changed the game. And better tamponades, we have now heavy silicone oils, we have Densiron. These help in the situations where there are multiple breaks in the inferior quadrants. And of course, better instrumentation. There are better forceps nowadays, better endocauteries. So all these things have helped us to improve our surgical results for vitrectomy in retinal detachment. So that is where I rest my case. Thank you.
Thank you, Preetham, for an excellent coverage of the aspect of vitrectomy. I think it was really great talk, and I'm really thankful to you for taking up pains to prepare such a good talk. Our next speaker would be Dr. Our next speaker is Dr. Nishikant Borse, and he'll be talking out again on a very important point for discussion: vitrectomy versus scleral buckle. As I said earlier, scleral buckle is an art which is probably being sort of pushed aside, but I think at the same time it's there's to stay. So now let's look at what Dr. Nishikant has to say. Nishikant, as you know, is an practicing vitreoretinal surgeon in Mumbai, also an alumni of JJ Hospital and Shankar Nethralaya. And obviously, he is on the forefront of all the new happenings in vitreoretina. As you know, he is one of the, I think, most seen face on the webinars nowadays. And he is the Red Buckler Award winner for his internationally popular video on CRAO management. Nishikant, please.
Yeah, okay. So I have got the job of comparing Dr. Prabhu Desai with Preetham, because I'm going to compare scleral buckle and vitrectomy, and I hope it is not penalized. Okay, so let us see what has happened. What has happened is, with the surgical techniques evolving, the prognosis of rhegmatogenous retinal detachment has become better and better. But we have still not reached an agreement as to what is good, whether it's a buckle that is good or whether it is the vitrectomy that is good. But one thing is for sure, the art of scleral buckle that was being transmitted from generations down is now going down. And many a times people rather combine both these procedures like a buckle or a band with a vitrectomy to give good results. And like Dr. Prabhudesai had said, it is basically now what is happening is that scleral buckle being a difficult technique, it is not getting transmitted down, or the skill transfer is not so much as vitrectomy. And that's why vitrectomy is becoming more preferred. It is basically because it has started evolving, and it has greatly evolved from 20 gauge to 23 to 25 to 27. The wide field viewing systems has made this visualization so good and accurate that people prefer to directly see the retina rather than do an indirect ophthalmoscope and bend their backs. Like Preetham said, the better cutters and vitrectomy consoles with their duty cycles have improved the vitrectomy as an experience itself and the chances of success. Also, from the patient point of view, there is less pain immediately after the surgery, and even in the long run, we know that the buckle thing can really be painful as much as up to 6 weeks for the patient. Now, most importantly, what has happened is, but the past plan of vitrectomy has become easier to teach now. It is basically because you can see it on the monitor. You can have a 3D experience. So teaching a past plan of vitrectomy is become a more easier option for teachers as compared to teaching a scleral buckle. And we all remember from our Netrala days how much our teachers had to bend their backs literally to teach us about that. But there's a disadvantage to it also. Vitrectomy requires post-operative positioning as per the gas bubble or silicone oil. Okay, it also causes a rise in IOP and cataract, which is almost there in 80% of the people, as we know. In pseudophakic eyes, it can cause an IOL to get subluxated or decentered, and the retinal folds and PVR can occur. Remember one thing, vitrectomy is a very less forgiving surgery. If you fail in a vitrectomy, you get a very severe complication as compared to a buckle, where you might just get a retina which is not well settled, but you will not get that severe PVR, and you can always go back and settle it with a secondary vitrectomy. The other major drawback of a primary vitrectomy is that it is still associated with high rates of anatomical and functional failures. Now, that might seem surprising to most of us, but if you really look at it, there is a 100% chance of success instantly. But if you see as the honeymoon period gets over, from weeks to months, we start seeing that the same very eyes with oil or with other PVR coming in, you get late failures, and the success of a buckle always stays, but the success of a vitrectomy may not always stay. And that's why that leads to overuse of silicone oil, and that makes the surgery more expensive with PFCL oil and the newer gadgets to come in. Scleral buckle, it's an extraocular procedure like Dr. Nitin Prabhudesai said. It does not induce cataract, it's low budget, does not need tamponade, doesn't need sophistication. And now we can have a chandelier assisted scleral buckle. That will help a better visualization and more comfort of surgery. And we can teach more on a chandelier assisted scleral buckle. The only problem is it makes your globe out of shape. It can cause a muscle imbalance. It can cause a squint. It can cause diplopia. And you require a lot of skill. You need to bend your back. Basically, scleral buckle is nothing but having a good IO, and many people are not willing to do that today. Also, the use of cryo can have increased chances of PVR. But still, whatever you say, it's a better technique in younger eyes. So if you just compare both of them, you can see that the single surgery success rate is actually more in a scleral buckle as compared to a past planar vitrectomy. And this chart sort of enumerates all the positives and negatives that you can see in a scleral buckle vis-a-vis a past planar vitrectomy. Now, as we know, scleral buckle is basically indicated in a detachment which is non-complicated in a young adult with a partial detachment of 1 or 2 quadrant in a phakic eyes, detachment with minimal vitreous changes, and detachment with anterior retinal breaks or dialysis. Whereas vitrectomy will be definitely there in a thin sclera, GRT, multiple tears, vitreous tractions, vitreous opacities, hemorrhage, and recurrent retinal detachments, associated pathologies like macro, etc. So like vitrectomy can be done in all the indications, scleral buckle can be done only in these indications and gets ruled out the minute you go there. Now, remember the studies that have been done to compare pars plana vitrectomy and scleral buckle are basically done on these indications and not on these. So when you keep that in mind, you will be not surprised to know that the visual outcomes are comparable in both. There is really not much significant or anatomical or functional difference between scleral buckle versus PPV. But Park et al. Have reported that PPV might show better outcomes as compared to scleral buckle in older phakic patients, and that might be because already you can have the PVD that is there, like Pritam had mentioned. So if the PVD is already there, you're not going to induce a PVD, you're already going to dissect the vitreous better. The PPV might give you a better sort of success. In pseudophakic eyes with uncomplicated RT, the initial and final anatomical outcomes have been reported to be better with PPV alone or PPV combined with scleral buckle. So these are the few of the surgeries. There have been a lot of surgeries, the studies that are done. But one of the main study was the SPR study group, which studied both the scleral buckle versus PPV. And you can see the anatomical and the functional results in both. But if you see in phakic eyes, the scleral buckle, the single surgical success rate is 63%, and PPV is also 63%. But when it comes to pseudophakic eyes, PPV gives you a much better success rate as compared to a scleral buckle. So in conclusion, the controversy still continues. We can go on and on debating which is good, which is bad. I think it is basically more with what the surgeon is comfortable for that particular indications. It has to be individualized as per the surgeon's preference and comfort with a particular technique. There's no point trying a technique which you're not comfortable with. But scleral buckle, although we might call it as an old technique, it still holds good and can give excellent results if it's performed well. And if you really follow the old traditional Netrale style, I'm telling you, scleral buckle can definitely give fantastic results. And it will be definitely advisable for young retina surgeons to acquire this skill set. Just to finish off, I still prefer a combination of both. You can do a buckle to the areas. This is the coloboma case in which I put an encerclage plus a buckle in the superotemporal area. And what happens is it gives you a fantastic visualization of the breaks. It gives you a good support of the breaks. It supports even missed breaks. It even assists you in doing a good endo laser in the end, and you really don't need to put oil for a long-term visual gains. Thank you. Thank you very much.
Thank you, Nishikant, for your kind talk here. I think, am I audible?
Yes, very much.
Okay.
Yes, sir.
Thank you, Nishikant. It was really an erudite presentation. You really took pains to compare both the procedures and have given a very clear perspective for anyone who is really wanting to debate. I think there is not much point left for us to debate. It's, as you said very clearly, you do whatever you're comfortable with, and you should know your limitations and your procedure limitations in taking the final decision. Thank you very much for your very, very good presentation. Now, our next
Welcome.
speaker in line is Dr. Ashish Vaidya. Ashish, are you ready? Yeah, I can see your slides. Yeah, Dr. Ashish is a practicing vitreoretinal surgeon, and he has his own clinic, the Netra Retina and Laser Institute in Mumbai. And he's also a consultant with Lilavati Hospital. And obviously, he is a Shankar Netra alumni and one of a very good academic person who has been relentlessly attending all the conferences and giving his excellent presentations in all the conferences he attends. I would like him to start with this presentation, and he'll be talking to us on a very important topic, which really usually we don't discuss. That is an intraoperative change in plan. As I said, sometimes you may start with a buckle and end up with vitrectomy, and sometimes you start with vitrectomy and you'd like to add on the buckle in this situation. So I think Ashish will give us a good idea on this particular problem. Dr. Ashish, please. Unmute yourself, Ashish.
Ashish, we can't hear you.
Ashish, we can't hear you.
Something to do with your earphone, bro.
By the time Ashish gets ready, I have an interesting tidbit. I was just talking to Preetham. Of all the 6 co-instructors, we all have daughters who have joined medicine. And Preetham doesn't have a daughter but has a son, but he is also joined medicine. So I think we are fathers and we are ophthalmologist mothers are probably role models for our kids to join
Sir,
medicine.
that means, are you saying retinal surgeons have a good influence or a bad influence on their children?
Probably good. Nish's children would definitely have a good influence because he's driving them around, you know what.
Or I think we are so bad that our children thought they will improve upon our results.
That is good one. That's a nice one.
Can you hear me now?
You can hear you.
Yeah,
but
we
your
can hear
presentation
you.
is not seen.
Okay. So I think I'm going to share the slides from the computer and speak from my phone.
Very
I just
good.
hope I don't get a call in between.
Okay, that's a good idea.
Yeah, we can see your screen.
Yeah, can you see my slides?
Yes.
Okay. And am I audible?
Yes. Nicely.
Sorry for this glitch. I think there's something happened with the microphone. Okay, so I'm going to talk about intraoperative change in plan in the retinal surgery. So, yeah. So retina has multiple choices for treatment. As we have known, you can do this way, you can do that way, there's the other way. So ultimately, which is the way you choose? And in retinal surgery, you have to keep on making choices. So it's always good to make the right choice, and hopefully you should not have the wrong decision. As Nishi has also said, till the 20th century, retinal detachment was equal to sterile buckle. It's a surgery which has come up right from the 1960s, and people are still doing it and gives excellent results. PVR D1, D2 or D3 was only vitrectomy. But there was a paradigm shift. The advent of small gauge vitrectomy made it that vitrectomy was a procedure of choice, and hence the incidence of shifting from one procedure to the other has dramatically reduced. It was a procedure of choice in pseudophakic patients, in phakic eyes with PVD, in posterior breaks, head cosmesis, and recurrent episodes of redness or infections. So buckle in the modern era is more of an exception and can happen in peripheral breaks in young phakic patients. So what is the indication for intraop conversion to vitrectomy? Well, if you're doing a buckle and at times you see that there are posterior breaks, you're not able to go that much behind. Sometimes there's a vortex vein present over there and you can't go behind. Or you don't want to put a 280 or the 281 buckle because that will cause a lot of indentation. The indentation may go right up to the macula. So in these cases, you can suddenly decide to change the pattern and decide that have a break which go over and do a vitrectomy instead of doing the buckle. Then sometimes there can be a large amount of residual. Hello, can you hear me?
Yeah, we can hear you now.
Yes.
Please go ahead.
Hello.
Yeah, we can hear you.
Yeah, can you hear me?
Yeah.
There was posterior breaks which may be pre-existing or due to perforation. Sometimes there's a large amount of residual fluid which is present even after drainage. As somebody said, Nitin said before, you can have bleeding from the drainage side. This bleeding may be subretinal or it may result in vitreous hemorrhage. You can have PVR or subretinal gliosis, preventing apposition of break on buckle. In these cases, you can go ahead and do a vitrectomy at the same sitting. However, there's a problem with this. This can involve sometimes medical, legal, and psychological issues. If you have told a patient that I'm going to do a buckle and then do try and attach the retina, and you go in on the table and do a vitrectomy and come out, I don't know. I mean, because a vitrectomy will predispose the patient to cataract. If you put silicone oil, it may have oil removal. So it may have certain issues which are there, and these need to be well explained to the patient. So I think in every patient in whom you are doing a buckle, you should tell them pre-operatively only that I'm doing a buckle, and in case I need to do, I may go ahead with a vitrectomy at the same sitting also. Now, What about vitrectomy change to buccal? This is very rare because you have already decided pre-operatively, I'm going to do a vitrectomy in this patient. However, sometimes if you do a detailed examination under anesthesia and with the pupil fully dilated, if the surgeon feels that the buccal would be a better choice, especially in young phakic patients. Like you have a patient who's a young patient of, let's say, 3 or 5 years old, and you want to take up the patient under general anesthesia. At that time, you can examine him in detail and decide that maybe vitrectomy is not as good, and we may decide to do a buccal in this patient. So that would be one indication of changing back from a vitrectomy to a pure buccal. What about the other thing? That is addition of a buccal to a vitrectomy procedure. Most of us today do a pure vitrectomy procedure and we do not add an encircling band to it or a buccal to it. However, in patients with inferior breaks, if there's peripheral unrelieved retinal contracture, or in young phakic patients, you may need to have a vitreous base support. If you put an encircling band in these patients, then to do a laser photocoagulation 360 degrees is very easy. And this is something which can be done. So addition of a buccal to a vitrectomy procedure can be done in these patients. But at the same time, one must remember that only the soldier knows what happened to the battlefield, on the battlefield. Whatever decision is taken on the table is the right decision, because that was a decision taken under stress, under duress. So whatever tough decisions are ahead cannot be dissected later on in hindsight. Later on, you can't say that, oh, I could have done this, I could have done that. Whatever decisions were taken by you at that time are tough decisions and they need to be implemented. And hence, you need to find out what is the right decision and come to a solution. The solution may be solution 1, 2, or 3. You may decide that, okay, fine, in this case, I've started with a buccal, I'm going to do a vitrectomy, or I'm doing a vitrectomy and I think I'm going to put an encircling band around it. So these are various solutions that can happen. And for one brief moment, I'm going to just dwell on this, which is, I think, extremely important to this talk. And that is summary of primary retinal detachment outcome studies, 6 reports. These reports have dramatically changed what we are going to do in the future. These reports have come in 2019, 2020, and 2021. What the report number 2 states that it compared the anatomic and visual outcomes of scleral buccal, past linear vitrectomy, and past linear vitrectomy with scleral buccal surgery in phakic patients. And they concluded that in phakic moderately complex rhegmatogenous retinal detachment, scleral buccal and past linear vitrectomy scleral buccal was superior to PPV in single surgery anatomic success rate. Scleral buccal showed the best visual outcomes compared to other methods. So this study definitely shows that in young phakic patients, the best option is to do a scleral buccal. Then they compared PPV and PPV-SB surgeries in pseudophakic patients. And they realized that patients who are undergoing PPV plus scleral buccal compared to PPV alone had better anatomic outcomes, although the visual outcomes were similar in both methods. Then they compared whether you could give 360-degree retinopexy versus just focal retinopexy. And they concluded that 360-degree laser may be associated with worse anatomic and visual results. Then the fourth one was comparison of non-complex surgeries by using a non-contact system versus a contact system. And the final thing was that anatomic success rates were similar using non-contact and contact surgery. And finally, they compared anatomic and visual outcome between PPV and PPV-SB for inferior retinal breaks. And here they concluded that retinal detachment with inferior retinal breaks had a higher single surgery success rate if treated with PPV with SB compared to PPV alone. So this is a very significant factor. And hence, when we are doing a past linear vitrectomy and you find that there are inferior breaks, one should not hesitate to put a buccal, to put an encircling band. One can always put an encircling band also because it will give rise to a higher success rate. Thank you.
Thank you, Ashish. Again, an excellent presentation, and you really compared well between the decisions to be taken. And I think all the people who have attending this would have a very good idea of how you should decide on the surgery, and if things go wrong, how do you change the plan as needed. Our next speaker is the senior most of this group, Dr. Vatsal Parekh. Dr. Vatsal, are you ready?
Yes, please. Can you see my screen?
Yeah, we can see your screen. Dr. Vatsal, as I said, is the most senior of all. He's in 33 years in practice and 60 plus and going strong. Dr. Vatsal, we are really proud of you, a Shankar Nitra alumni, and I'm again additionally proud because he's also a TN Medical College and Nair Hospital alumni, my senior, and he's always a guiding force to us. Even at this age, he works extremely hard and also is in the forefront of getting newer technologies. As recently, he has got one of the best imaging technologies in India, and I hope that he keeps on going this way for time to come. Dr. Vatsal, your talk, please. Dr. Vatsal will be comparing the tamponading effect in vitrectomy of gas with oil, and I think he, because of his huge experience, it will be really good to listen to him on this topic.
Can you see my slides, Nitin?
Yeah, please go ahead.
Yes, sir. We can see, we can hear you.
So in this next 8 minutes, what I'm going to show is share my experience of last 3 years consecutive cases of primary rhegmatogenous retinal detachments and what our experience is compared to what Nitin and Nishikant and everyone said. So primarily I'm going to talk on tamponade. Tamponade means plug. So in vitrectomy surgery, tamponade essentially we mean internal tamponade, that is gas or oil. I'm not going to discuss about heavy silicone oil because I don't have any personal experience, and in my experience what gas I'm using is most often almost always C3F8 and 5000 centistroke silicone oil. So what data I'll be discussing is on that. Now, all we know, all of us know that sulfur hexafluoride would remain in eye for a week or 2 weeks maximum, and the interfacial tension is 70. I use C3F8 primarily because it remains in eye for 6 to 8 weeks, and I believe that proliferative vitreoretinopathy, the disease process is active for probably 2 months. So this is the best bet we have in combating PVR and supporting the break. And again, the interfacial tension is 70. Unlike that, silicone oil interfacial tension is only 35. So as far as tamponading effect is concerned, the silicone oil is half the of gas. So probably gas is a superior tamponade compared to oil. That is what I would show in my talk. 5000 centistroke I usually use because it has less emulsification compared to 1000 centistroke. Heavy silicone oils are not available in country and they are quite expensive, so we have limited experience. The advantage of gas, as I told you, has higher buoyancy and tamponade effect, whereas oil has longer tamponade. It remains in the eye till you don't remove it. The another advantage of oil is that air travel is possible, and third advantage is that vision is relatively better. If you operate a patient with 6/6 vision and do vitrectomy with gas, and probably for a month he may not have more than counting finger vision, so he may be upset, So, but the disadvantages of oil is emulsification, glaucoma, and band-shaped keratopathy. And even if everything goes well, you need to remove oil by second surgery. So I use gas practically in most of the cases. And when position is problematic, you can use oil. Now, these are our results of 3 years. We had 100 patients, consecutive patients, in which gas was used in 84 patients and oil was used only in 16 patients. We had success rate of 80% with gas, whereas success rate was 62% with oil. So we had higher success rate with gas, and I believe this is because of the better tamponade effect of gas compared to oil. Now, everyone discussed about inferior breaks and buccal and those things. Now, this what has been our experience, I'll share with you. Now, of the patients who were attached 76, 22% had inferior breaks, but still were attached with vitrectomy and tamponade. And of the 24 patients who were detached, so 24% who were detached, only 21% were because of the inferior breaks. So I feel inferior breaks, gas, or vitrectomy and oil is a reasonable choice because not all inferior breaks fail. Many inferior breaks settle with vitrectomy and gas or oil. We'll just go in further sub-analysis. Now, these are the patients with inferior breaks. There were 20 in the gas group and 2 in the oil group. Now, in gas group of the 20, 17 were attached and 3 were detached. Whereas in oil group, in my experience, both the patients were detached. Now, putting additional buckle. In 18 patients, I had not put buckle, but still 15 were attached and only 3 were detached. And in 4 patients, I had put buckle along with vitrectomy and internal tamponade. Only 2 were attached and 2 were detached. So I believe that putting buckle may not give a great success in inferior breaks. It's primarily also because of PVR process that the retina detaches. So to summarize, buckle or oil has no advantage over gas tamponade in inferior breaks. That's what I would probably feel. Now, if we classify by PVR all these 100 cases, we had 83 cases with PVR B and 9 with PVR C and 2 with PVR D and 6 with long-standing detachment. And what we did with gas and oil, we'll just go through that. In PVR B, the tamponade of choice was gas because 78 were gas and 5 were oil-filled eye. Of the 5 oil-filled eye, 50% had detached, 2 were attached and 3 were detached. Whereas with the gas fill of 78, almost 80% were attached, 62 and detached were 16. In PVRC, we had about 9 eyes, and of which in 4 I'd used gas and all 4 were attached. I'd used oil in 5 cases, 50% were attached and 50% were detached, 2 and 3 were the figure. So here both places we have 50% with oil, whereas with gas, the ratio is more. Now in PVRD, I'd used oil only and both cases were attached. In long-standing detachment, where I'd done vitrectomy as a primary procedure, the 6 patients with gas were attached and 2 were detached, and with oil, both 2 patients were attached. So probably long-standing detachment, our results were better with oil, though the numbers are small. Now, this is an interesting observation I got to know from my series that 32 eyes of phakic eyes and vitrectomy was successful in 80% of cases and 20% there was failure. And pseudophakic eyes also 75% were attached and 25% were detached. So probably the results were not bad in phakic eyes, they were quite good. So I think vitrectomy can be considered as a primary surgery even for phakic eyes. Probably I have not included patients less than 20 or 25 years of age. So probably all these patients would be 40 or 40 plus or 35 or 40 plus. Now let's go through some of the cases. Now this was a superior giant tear which got attached with vitrectomy with C3F8 gas. No oil was used. This was inferior giant tear. Again got attached with vitrectomy with gas C3F8 and no buckle or no oil was used. Now this is one of the recent patient with a giant tear and this is with gas C3F8 and you can see that the giant tear has been very well opposed and you can see a good laser mark. So in fact, I don't do a belt buckle for giant tear and normally I don't do belt buckle now as a routine. Now this was the inferior horseshoe tear which had undergone vitrectomy with gas. It failed. I had done re-vitrectomy with oil, but it still failed. Probably a buckle would have been helpful in this patient because the recurrent detachment was because of the breaks at the vitreous base. Now this was a case of PVR C1 again got attached with vitrectomy with C3F8, only one surgery. Now this was a case of anterior PVR and PVR D3. This patient I had done lensectomy with vitrectomy, oil and buckle and this got attached. Now this is a patient who was very unfortunate. This was a patient where I thought pneumoretinopexy would help. I did pneumoretinopexy. The retina got settled. He recovered 624 vision. But however, after 3 weeks, he got detachment again. And with the same break which had reopened, which was at upper nasal quadrant. So I did vitrectomy 23 gauge with C3F8. Unfortunately, on 8th or 9th day, he had hyphema, and I thought patient had bleeding disorder. Retina was attached with C3F8 on sonography. We couldn't pick up detachment for almost 5 weeks following surgery because C3F8 would remain in eye. And when I operated again, he had a large tear, which was probably a cause of hyphema and vitreous hemorrhage. And this patient did not do well with revitrectomy and lensectomy and silicone oil and buccal. So to summarize, microincisional vitreous surgery with gas tamponade is most rewarding procedure for primary rhegmatogenous retinal detachment. For inferior breaks, vitrectomy with gas work equally well. Use of oil is good for certain selected patients. Phakic eye do quite well with vitrectomy, just like pseudophakic eyes. And PVR is the most important contributing factor for surgical failures. The next common being in my study has been iatrogenic complication during vitreous surgery, that you create breaks or something that could be associated with worse results. Thank you for your patient hearing.
Thank you, Dr. Vatsal, for an excellent presentation. And I'm really impressed that you took all the pains to present your data on this. We are really privileged that you considered this IC as important to present your 3 years data. It's really a great work. And I hope that you would be able to present a paper on this and we would be able to see it in a very good international journal.
It was a good
I
thing
think
for me
you should pursue it.
back.
You should pursue it, I think, definitely.
It was a good
because
thing.
It is give,
You know.
because it is giving really good insights.
Yes.
Because
Agree.
the similar paper was there in BJO where they are said that only vitrectomy with gas is sufficient for inferior breaks. It was a paper a few years back, but we really still don't have the confidence of using only vitrectomy with gas for inferior breaks. So most of the time we would tend to put a buccal. Many a times we would tend to put in silicone oil. And I think work like yours would definitely give us a new idea, and we can definitely try in most of our patients to consider gas as an alternative to silicone oil.
Correct.
I think now we have some time left. I think almost 10 minutes now. I think each one of you, if you have some comments to speak on other topics, and if you wanted something specifically to be said about the whole procedures of the retinal detachment in primary retinal detachments, please go ahead. We'll start with Kumar. Kumar, you have anything to say?
No, just a comment about with the band or not to use a band. There was that we alluded to that. Many speakers alluded to that. Preetham and Vaidya, Ashish Vaidya. One famous surgeon said that a buckle or a band be a complement to a well-done vitrectomy and should not be a supplement to a poorly done vitrectomy. The retina won't reattach irrespective of whether you use a buckle or not if the internal job that you have done in that patient is insufficient. But after having done everything that needs to be done internally, if you still feel that some insurance can be got with a buckle, with a band, then we go ahead and put it in. But it should not be used in the hope that the retina will reattach when the job internally has not been properly accomplished. So it's a complement to a well-done vitrectomy, but should not be a supplement to a poorly done vitrectomy.
Very well said, Kumar. I think it's a really important point that we should not try to cover up our sort of shabbiness with a SADC support from outside. I think that's a really good point. Preetham, you want to say something?
So actually, I just had. I would rather throw it open to to all the speakers. I mean, how many of us are really doing cataracts, phaco with IOL and retinal detachment surgery with tamponades and buckles? I mean, I really didn't touch on that aspect in my presentation. So if we can have some views on that,
Yeah, we'll start with Vatsal Bhai.
Yeah, can you hear me?
Yeah.
Yeah, I do not prefer doing.
So what the reason I ask this question is, like, if there's a macular hole and a little bit of cataract, we prefer to do combined. So that's why I'm asking this. Whether for Reg RD also we would do the same.
I did for 1 or 2 patients, Preetham, and I found the inflammation to be more compared to regular vitrectomy. So some other I would avoid doing all together. If cataract is really dense, maybe I would consider doing phaco or fragmentation, but probably not IOL because the inflammation part is much more. And with biome, I have patient, I can send you photographs where it was like any cataract surgeon would do cataract. You know, it was such a brown cataract and I could settle retina with vitrectomy and do cataract after 4 months. There are two patients like that. Because with biome visualization is quite good. And thirdly, I think in my practice, if I do cataract, IOL and vitrectomy, the bill goes too high for patient to trust to somebody else. No. So I would rather do it in 2 stages.
Thank you, Vatsal.
Pritam,
I think Vatsal, he
the
has always
problem
a very,
is-
very down-to-earth response and a very practical response. Nishi, you want to comment?
Yeah, so when we are doing both together, there another big problem is the IOL power that you're going to put. Okay, now suppose there is a scenario where there is a very, very dense cataract and an RD. Whatever you do, you're not going to get an accurate power, number one. Number two, you really don't know how bad the retina is, so whether you can use just gas or you can use oil. When you use oil, again, there's a hyperopic shift with an IOL, and then again when you remove the oil, so it makes the whole scenario very complex, and it doesn't really lead to very good results. So even if there's a cataract, I would agree with Dr. Vatsal Parekh that I can do the cataract, leave the capsular rim intact, and then maybe combine it with silicone oil removal if I have to put silicone. And if the patient has just got away with gas, then it's just a question of injecting the IOL later.
Thank you.
Ashish,
Yeah,
because
can you
he does
hear
a
me?
lot of combined surgeries. Yeah.
Yeah, Nitin, can you hear me?
Yes, yes.
Yeah.
Yeah.
Okay. So I think, I wouldn't do combined surgery. If there's a cataract which is that dense that you can't see the retina at all, only then I may think of doing a combined surgery. What also happens in combined surgery is that your anterior chamber is very unstable and it keeps on fluctuating. So there's a very high chance of the silicone oil or the gas migrating to the anterior chamber. Now, if gas migrates to the anterior chamber, it's okay. It's not a problem. You may have at the most a slight underfill and you can inject gas again. But if silicone oil comes onto the anterior chamber, then again you are faced with corneal endothelial problems and other issues which are there. So I think as far as possible, I would avoid doing cataract with a retinal detachment surgery.
I think for scleral buckle, most of the time we prefer if there is a little bit of cataract or maybe a little denser eye, and if your break is well seen, we would definitely go ahead with a routine scleral buckle and then do the cataract surgery, because then your cataract is as a routine cataract. For vitrectomies, yes, unless, as you said, if there is a very really bad cataract which doesn't allow you. Other than that, most of the time we would try to avoid doing a cataract surgery for the RDs. Whereas for macular holes, as Preetham rightly said, we many of time combine the both. Nishi, your comments, please. Overall.
I would just like to sum up saying that I still believe in the surgery called scleral buckle quite a bit, because it's like I mentioned, it's a very forgiving surgery. You do a scleral buckle, if it doesn't work, you go in after about 2-3 weeks or even 2 weeks if it is early or detachment is huge, and you do a good vitrectomy, you're going to settle it definitely. But the same cannot be said about the vitrectomy, even if we are becoming more and more comfortable with vitrectomy as we practice more. So if I have a young phakic, I will definitely look at scleral buckle, and maybe if it's a pseudophakic with one hole or two, then I will still consider past liner vitrectomy, because it's just the ease and the faster surgery, and the vitreous being liquid in older people makes the things much easier.
Preetham?
Yeah, so I see a lot of youngsters doing combining phaco IOL, but I don't know, maybe I'm a little old school thought, but there is a dense cataract and I'm doing a vitrectomy for reg RD. My personal approach is to do a fragmentome, do the cataract, just leave the patient aphakic with a good capsular ring, and like Ashish suggested, maybe at the time of oil removal, then at that time or even in a third step, then put a secondary IOL.
Nitin, I would like everyone to opine when they would operate again for recurrent detachment. Say you've done vitrectomy, and you get detachment, or when you have done buckle and you get detachment, what is the optimum time you consider for resurgery? Everyone's opinion in short, if possible. This
Okay,
is a
we start with
confusing
Kumar.
field for me.
Yeah, it's very important to identify the cause of recurrence. If there is an unsupported break, a new break, etc., then you go in and attend to that immediately. But if the cause is not a new break and it's predominantly the proliferative vitreoretinopathy with
The
epiretinal
cause is
proliferation.
PVR. The cause
Yeah,
is
if it is-
PVR.
Yeah, if it is PVR, then waiting for about a week to 10 days for the membranes to mature to facilitate greater. That depends again on the age profile of the patient, the cause of the detachment, etc. So a 7 to 10 day period of waiting would do no harm in a case of a recurrent detachment, particularly if the membranes are premature. So you will be able to do a good dissection by waiting for 7 to 10 days. But again, we'll have to individualize depending on the case on hand.
Okay.
Vatsal bhai, you're talking about post-vitrectomy or post-buckle?
Post-vitrectomy primarily.
So
For
I use
PVR only.
Yeah. So I use a rule.
Yeah, please go.
I use a rule of thumb. If it's happened, if the recurrence occurs, after 4 weeks of the primary surgery, then I advise immediate resurgery. If the recurrence has happened within 4 weeks, then I would wait for at least 15 days from the primary surgery so that the inflammation in the eye is less. The eye is less inflamed from the primary surgery, and then plan it in the window between 15th to the 30th day. So this is a rule of thumb I follow.
Ashish?
Yes, Ashish.
Yeah, I think, one must also consider what is the tamponade which has been used in the primary surgery. If the tamponade used in the primary surgery is silicone oil, I think you can comfortably wait for 8-10 days, even 15 days, and let the membranes mature and then do it. However, if the tamponade used in the primary surgery is gas, then I think PVR develops very fast. And these patients, if you go in after 10-15 days, you end up with almost a close funnel detachment.
Correct.
So that I think is very important.
So Ashish, that's another reason, because your gas tamponade is quite good till the 15th day, and it starts going up to about 30, 60 to 70%. So that's why that window of 15 to 30 days is again for that reason.
Yeah, that's the time when you see the patient and you ask the patient to look down and you see fluid coming up. And then you start wondering.
That's the only place you look. The only place you look is at 6 o'clock. That's it. If that is on.
Nitin, the question I asked, the
Yeah.
reason is that suppose you operate within 10-15 days.
Yeah.
I've had patients where I operated within 10-15 days to find another membrane, another break later, maybe after 10-15 days. So, because PVR, what I believe is a disease process which may take about 2 to 3 months to mature, So probably waiting, immediately jumping in may not be the right way, because you can still get detachment again, But waiting too long may cause retinal contraction and you may need retinectomy.
Yeah.
So I still don't know the answer.
So, but as I think we'll have to wind up, the time's up.
Thank you.
Thank you.
Thank you, all
everybody.
of you.
Thank
Thank you very
you.
much for your
Thanks,
excellent
everybody.
presentations. I am
Thank you.
really indebted, and I think we should be able to do this again sometime in future. Thank you very much.
Definitely.
Good
Thank you
night.
so much.